I next request Dr. Sujith to carry on with his presentation on one of the most dreaded complications of laser vision correction, namely ectasia.
Thank you. Thank you, and very good afternoon to all of you. I'll be speaking on the tools to prevent and manage post-refractive surgery keratectasia. As Dr. Sapna told, it is one of the most unwanted complications that we have for the refractive surgery. The incidence roughly quoted in literature is 0.02 to 0.6%. And it varies from various types of procedures like PRK and LASIK and even SMILE. The ectasia was found to be, the key factor is around 4.5 times more likely after LASIK than PRK. And interestingly, this article, this was showing this picture in which you can see the yellow lines are those with a SMILE, which was actually introduced as a better refinement of the laser procedure to prevent. One of the motive was to prevent ectasia, but you can see over the years, the ectasia numbers in SMILE is also increasing. So the incidence is varying. It is different in various procedures. We are not sure about various risk factors that is involved, and there is some underreporting also that's happening. So commonly identified pre-op risk factors, most of them Dr. Shaji already mentioned. These are topographic variations, thinness pachymetry, pre-op keratometry, the PTA value, ERSS score, residual stromal bed. Most of them we normally look into. Still, it is told that up to 6% of patients can be picked. Retrospectively, when they look at those who had ectasia, at least 6% was missed during the pre-op investigation stage. So it includes, our suspicion should start from the patient's history, very early age, like what Sir told. Sometimes they are actually waiting for their 18th birthday because they know after 18 years we can do it. It's just not the age. We are also looking at the stability of the refractive error, which from history most of the time we won't be getting. Progressive myopia, any changing or new astigmatism as per the previous history. The disparity in the subjective and objective astigmatism, allergic background, chronic ocular inflammation, any association with systemic diseases like PCOD, thyroid dysfunction, vitamin D deficiency is also found to have some relation with this ectasia, some Down syndrome. All these things should make us think of a suspicion of that candidate, whether he can go in for a bad result. Those who regularly do refractive surgery, at one look, this is looking a normal scan to me, and refractive error is also not that much, just two diopters of cylinder. But I refused laser refractive surgery for this patient just because his younger sister was treated by me for keratoconus, and the C3R was done. So I was little scared, just immediate sibling, having a keratoconus, I would not touch this eye, at least waiting for next few years. So there are certain factors we know as identified risk factors. There are many factors which we don't know. So respect to Dr. Yaron Rabinowitz is a very common name in the field of keratoconus and topography. He passed away almost 20 days back, just 4 days before the World Keratoconus Day. He had put out these 10 most famous topographic patterns. This is commonly screened in our routine preoperative screening. He, along with McDonald, has put out some indices also for screening, which includes the central keratometry value, inferior superior value, and the skewing. But there are certain subtle things which we should not miss, or we should try to look for in suspicious cases especially. Not just the central thickness or the thinness pachymetry. We should also look for the coordinates of the central thinness point or the thinnest point. The Y coordinate is more important. Whether it's going down and temporally is one thing which you should look for. Another thing is the difference between the thinnest as well as the thinnest point with the apex. Also, pachymetry screens, most of these higher-end topography machines have these things incorporated into it. So you have to, the pachymetry, just not the pachymetry value, the progression of the pachymetry from the center to the periphery is also very important. And there are graphs and there are color-coded maps also to make evaluation much easier. So when these lines come out of this graph, you have to be really suspicious. Next important, other than the pachymetry, would be the posterior elevation maps, which we know the shapes, island shape and tongue shape are quite suspicious. We have to also look for the values and also the difference in the value between the elevation back and the front at the thinnest point. So these are all subtle things which may be adding some value to our regular screening points. After that, we have this ectasia risk scoring system. Most of these points are all same, but they have put it into one screening system or one scoring system, and to make things easy for us. PTA has already been explained. Anything more than 40% is strongly associated with development of ectasia. Bellin-Ambrosio scale, again, pentacam is, most pentacams have this attachment, and it's quite good screening tool for ectasia. Epithelial mapping is one newer advancement in the last few years, where you can look for a donut shape pattern of epithelial remodeling, which can be a clue for early keratoconus. But some fallacies also are there for these types of indices. For example, this I've taken it from an article. This patient was screened by Bellin and was found to be normal, but post-operatively he or she developed ectasia. So the bad criteria, Bellin-Ambrosio display criteria has got a sensitivity of 80 to 87, sensitivity of 80% and specificity of almost 78%, but still it's not 100%. So this one patient of mine where I have burned my fingers, it's only one eye is involved. He has come for a recruitment. I didn't have a previous history of his refraction. Only one eye, 0.75 cylinder. There is some skewing, some yellow flags, which I ignored. In just 3 weeks, he came with ectasia. Much to my surprise, because in 1 month time, he was having his recruitment. I thought it may be some epithelial remodeling, but in 5 weeks time, it worsened. Now, I had a bad time talking with the patient that I cannot help him to go for the recruitment, but I will have to definitely help him to regain his vision. Comparison map also shows clear-cut ectasia in this. I thought whether it could be epithelial remodeling. I did with and without epithelium. After removing the epithelium, I did a topography. There was actually worsening of the ectasia part. Take 2 more slides. So post cross-linking, actually he improved. He improved and he regained his vision 6/6 spot, and he got selected into police department. So post-operative risk factors also needs to be looked into, because it's not always, any ectasia may not be our missing or our mistakes. It can be something that happened, any event that happened after the laser refractive surgery, like pregnancy, allergic rubbing, PCOD, and even adenoviral keratoconjunctivitis is supposed to increase the apoptosis of the keratocytes. So when is ectasia suspected? It's earlier presentation, up to 2 weeks also it can present, like in this case, or late presentation. You can have progressive drop in the uncorrected as well as the best corrected vision, and with topography evaluation showing signs of ectasia. But definitely the regression should be ruled out, and it's quite easy to rule out the regression because the keratometry, you can see the central flattening. Once it is diagnosed, the options that is in your hands are stopping the progression with corneal collagen cross-linking, or even if it is a very early case, you can think of doing a topo-guided PRK along with cross-linking. Corneal rings generally gives good results for cases with ectasia, and if it is a last resort, you can think of DALC or a corneal transplant procedure. Cross-linking specifically in post-laxic ectasia, there is a controversy whether it is as good as in a keratoconus, but special concern we need to look for is, generally it's a post already treated eye, generally they have a lower pachymetry, and you may have to use a thin cornea protocol. And so it's time up, so I'll just summarize. So all attempt is to prevent the ectasia. Topographic indices remains the best reliable investigation. Most important determinant remains the RSB, the depth of ablation as well as the age. Various indices gives supplementary evidences only. Eye rubbing and post-operative risk factors also should be given due importance. Timely suspicion, early diagnosis and management can reduce a progressive damage, and unidentified factors still remain as hidden risk factors for ectasia. Thank you so much.
Thank you, Dr. Sujith. I had a question regarding that patient, because you have actually aroused our curiosity so much. So what was...
show that? Show up that?
Yeah, please do. What was the thinnest pachymetry reading there, and What was the dioptric power corrected?
0.75. 0.75 cylinder. He was 6'9" parts, just short of his recruitment criteria of 6'6". I normally don't take up, but obviously they do pressurize, and if it's for a job, we tend to sometime.
And was it matching the topographic cylinder and the acceptance cylinder?
I think topographic was 1 point. Yes, it was 0.9. The manifest was 0.75.
And the pachymetry, the thinnest?
Pachymetry thinnest was 4, I think it's 480 range, 480, 498 or 488, I'm not very sure.
Okay, so overall, it is, what do you have any comments on this, Dr. Tushar? Because can we have some? Like we
Yeah, so
yeah, we're just, trying to analyze
so aside from
how
the
such things.
obviously PTA is not going to be an issue in this particular patient, but I think depending on the practice, we at RP Center keep 480 as the absolute sort of final cutoff. If it's 480, even a micron below 480, we don't touch the cornea with any laser. But as Sujith said, it was like in that borderline group. But the other thing which I have seen personally from the referred cases and from whichever cases we have had ectasias, it's the most unexpected patients who who get ectasia. I mean, I have never seen a patient with high sort of refractive errors getting ectasia actually. Whatever ectasia I have seen, it's been in the low to moderate group of myopia. I have never seen anything happening like this fast or in this low degrees of refractive error. But I have definitely seen ectasias presenting with having been treated for -1. So there are factors which are sort of right now which are not very clear to us. What is causing the patient got other eye was also treated?
No, other eye was
Okay.
6'6" unaided.
Okay.
Actually.
So as I said, the factors which are causing ectasia, I think right now beyond our understanding at this point or beyond our reach. And the best thing we can do from the medical legal point of view is having a complete documentation and our SOPs in place.
In the same vein, I have had a patient who had equal powers corrected in both eyes, and like you said,
Yes.
it's never very high. It's -2.5 or
yes,
-3.
it's 2.5. Somehow it's the most common thing is
And
2.5 range.
One eye went into ectasia, the other didn't.
Yes.
So, I mean, how do you account for that? So, I mean, does it put a fear in novice surgeon's mind that,
No, I
you
think
don't know what
as
you're
long as
dealing
your SOPs are strong and your practice is ethical, I think there is nothing to fear about. But your SOPs need to be strong. Like you have to have very strict criterias for. I mean, there should be yes and no criterias. No should be no in refractive surgery. You can't change your goalpost in refractive surgeries.
No, I'm also surprised at the way it responded to C3R. It is almost normalized now. See?
Yeah, that is also.
So it's very
Something unusual.
Fluctuating, yeah.
I mean, I've never seen getting an ectasia in 5 weeks and then responding so quickly to
in
CXL.
literature the shortest is 2 weeks.
Okay.
Actually, I searched after this.
Yes, absolutely. No, I'm not saying that it's not
Yes,
accurate, but I'm saying that it's surprising. But at the same time, if it is responded to CXL, I think we'll definitely like to have how the patient behaves in the final period.
Would you prophylactically do a CXL for the other eye?
We'll have to think in that line if this continues.
Yes.
Yeah. What was the age of this patient?
He was 22, 23, that age.
Could you enumerate the SOP that, like
He's
for the
22.
benefit of the audience, some salient points that have to be, fixed before taking up any patient for laser refractive surgery? Maybe the
See,
5.
obviously, one is I normally look at there is criteria for the pachymetry, the RSB and all. I also look at I slightly differ from what Sir told. I will not jump into a laser procedure at 18 if it is for a cosmetic thing. I will ask them to wait for, because this 18 thing is mainly, I may take it as a criteria only if it is a recruitment thing. I've seen those who have done at 18, most of them comes with some sort of regression later on, especially females after the childbearing age, they tend to come. They are still not stable. That's what I believe. 480, 300, RSB, these are all standard things. But see, in this case, even if it is 480, what is the amount of tissue that I am going to ablate? That is what I thought. And if it's giving someone a job, he's otherwise 6'6" in the left eye. So there is some emotional things coming in between. That is, and that's where we land in problems.
Any comments?
Should you not examine for systemic disorders, dormant, high ESR?
So if there is any sort of suspicion or any sort of anything in the history, see, to be very frank, this is my second case of ectasia. First case of ectasia was 10 years back. Dr. Priya may be remembering that case. He had a skin disease. He had a skin disease which I overlooked actually. And that also, actually that patient came with ectasia within 3 months, both eyes. So, probably.
Yeah. So I think